Okay, welcome to the Words Matter session, How Language Literacy is Shaping Patient Understanding. I am Samantha Carlson. I'm the Director of Research here at MBDF. And before we begin, I'd like to start sharing some housekeeping items that Dr. Norris had mentioned in the last session. If you have any technical issues, please if you're having technical issues connecting to the session, please click on the question mark at the top portion of your screen. That will direct you to the help guide and the system check and troubleshooting guide. And if you're still having issues, please reach out to our teammate Sierra De Leon at cdeleon@bleeding.org and visit email for questions. To send questions to the speakers, click on the Q&A icon on the left side of the screen on your page. We will be asking questions to the speakers at the end of the session. The questions you type into the Q&A module will be visible only to you and the speakers. To access the session resources, please go to the resources module located on the left side of the virtual platform in the lobby. These will be available at least 24 hours when the summit ends. Thank you to our sponsors, Sanofi, CSL Behring, Hemophilia Alliance, Pfizer, and Takeda. This session is recorded and will be available after the summit, and you will receive emails when all sessions are available for viewing. Thank you very much, Kate. So I'm Samantha Carlson, the Director of Research. And Kate, would you like to introduce yourself before we get started?
Sure, happy to. Hello, everyone. Thanks, Samantha. I'm Kate Naumacher. I am the Senior Vice President of Education here at the National Bleeding Disorders Foundation, and we are very excited to be sharing a little bit more about why words matter and some examples of how we bring this all to life through both clinical side as well as education. So with that, I'll hand it back to you, Sam.
Thank you, Kate. Okay, so our objectives today are identifying how language literacy and levels and communication norms can unintentionally create barriers to care, particularly with folks that have historical issues with marginalization, women, and people who do not have English as a first language and that are seeking services in our country. Also, we're applying practical strategies and to improve patient understanding and engagement by using plain language, culturally responsive communication, and health literacy practices to promote trust and equity. So today in this session, we're going to talk about definitions, which our CEO covered a little bit in the first session, why words matter, language and literacy in the clinic, and also in the education realms. And then we'll have some time for some Q&A. We do know that we're only covering clinical and education in this session, but there are other sessions later today and tomorrow that will cover more. So let's talk some terms, just so we're all on the same page. We used the information from the CDC to start with the definitions that we're using throughout this platform. So personalized health literacy is for the individual and the caregivers and the family members. So personalized health literacy is the degree to which individuals have the ability to understand and use information and services in the health realm and of how that's going with their healthcare and their health providers as well as their team. Organizational health literacy is when we're looking at the system overall. We're looking at the hospital systems, clinics, universities, and how the organization and system is looking to understand clear language and communication to people and families.
So NBDF is part of the system, right, Sam?
Yes, of course, as a nonprofit organization. Absolutely, absolutely. So to continue with our definitions, plain language is common communication that does not have a lot of medical jargon and that is easy to understand. Historically, it was known as layman's terms, but in this day and age, we're calling it plain language. Preferred language is the preferred language that an individual and their family would prefer to have their healthcare delivered in. So for example, if English is their second language, their original language might be their preferred language. And then cultural and linguistic opportunities for appropriate language is considering the culture of the family and where their family of origin is from and what the system of the family looks like and how we want to make sure we're sensitive to those needs and beliefs. Kate, if you could go to the next slide. Thank you. I'm going to let my notes catch up with me here. Well, go ahead.
I was just going to say, I can take it here on why health literacy matters.
Thank you.
Yes. Now that we have a little foundation of what terms we're using and why, Phil touched on this in our previous session, but why are we even talking about health literacy? Why is this important? So What's really interesting is there's declining literacy in the United States overall, like not just health literacy, but just regular reading, all of that, how we're retaining information. And so health literacy on top of that, of course, then is an additional issue. Information is becoming, even though there's so many ways to get information these days, particularly health information is becoming more and more inaccessible in a way that people can really retain, and it's too complicated for at least half of Americans, right? That's a problem that we have to address here. There's a 17-year research gap between when the findings are first, finalized, and probably even longer from when the research starts, to actually get fully down and out into the care and in a way that people can understand. So how do we shrink that so people can have, more meaningful clinical information right away? And this is all also in the environment of widening health gaps. These gaps put many Americans at higher risk for delays in care or worse health outcomes. So that's why, that's just kind of where we're at on health literacy. But don't worry, I didn't mean to completely depress you all, because we're here for some action today. We're here for some solutions. There's real research around why actually addressing health literacy really does have a positive impact, right? So it's highly beneficial. And these are just a few examples, right? So where they've been able to improve health literacy, there's been more preventative services that people actually use, such as pap smears or flu shots, right? So they can prevent further issues down the road. Improvements in how often patients take their medications as prescribed, and better conversations, that shared decision-making between healthcare providers and patients and families. Those all improve when the systems and individuals take steps towards addressing health literacy. And with that, I'm going to hand it back to you, Sam.
Thank you very much, Kate. So in the clinical setting, we're going to talk about the clinical setting and the aspect of the clinics where people go get bleeding disorder care, universities doing research, and people seeing patients and caregivers throughout the system. If we could go to the next slide, Kate, we'll talk about those systems. This is kind of depicting how they all integrate together. So at that baseline, we have the federal regulations. So in the United States, we have accreditations and requirements for access for understanding health, literacy, communication, and making sure that patients and caregivers understand their choices and their patient rights. And they have access to informed consent and care. Each healthcare system is a little different, but the overarching federal regulations require that systems have policies and procedures in place to address what we're talking about today. When you go to the institutional practices, each institution has their own policies and procedures based on that federal regulation, right? So specific tools in the clinic might sound like something like a pocket talker, which helps amplify hearing for someone who is hard of hearing but doesn't have hearing aids that can help them hear the information given to them. Or translation services. We prefer to have in-person translation services, but sometimes that's not always feasible or financially equitable or accessible for everything that's needed. So sometimes telehealth can help give a broader spectrum of, if we're looking at sign language or other nationalities or linguistics that people can't necessarily get locally. And then audiovisual tools. It might look like a picture board for someone who can understand what's being told to them, but is aphasic, meaning they can't express what they're thinking. And so they would point to a picture saying, let's say they wanted a glass of water. So using tools like that, based on the policies and procedures and practices of that specific institution, help make communication not just a language conversation and communication. And then the team approach. So then you drill down to, in that system, each team might have their own specific process and the tools that they use. For example, the team that works with stroke patients might have different tools than the ones that work with cancer patients, depending on what they have seen as the issues that they might need, all of which focus on plain language, making sure they have visual aids and specific steps and interactions to identifying communication barriers and how they can help address them. For example, teach-back methods are something that they use throughout the clinic, regardless of what diagnosis family that they're treating, where they're trying to have patients actually explain back the information that they receive so they understand that there's not any complications or confusion about what's been taught. So resources can help in the clinic, both the patients and the caregivers, but also the clinicians. On the next slide, we'll show you the person-centered care model, and this shouldn't be too foreign to most folks, But at the end of the day, the patient is at the center of the care team. So when we have these conversations around communication, gone are the days where you go to a clinic and your healthcare providers tell you what your options are and you have to pick one. It's a conversation now. It's a two-way conversation. So now more than ever, we need to make sure that folks understand. And if I actually drew this out the way that I wanted to, it would look a little crazy with all the arrows going from the social worker to the insurance team to the medical assistant to the doctor. Everyone is talking to everyone in that outer circle, but everyone is also talking with the patient and the family in the middle. Or here at MBDF, we call them lived experience experts. On the next slide, we'll show you some of the evaluations in health literacy. You know, when you go to a clinic or a healthcare setting, you're asked a lot of questions. And a lot of times when we're asking so many questions, it can feel very overwhelming. And honestly, sometimes it can feel very burdensome and very breaching on that privacy. But there's a reason we ask those questions. It's to make sure we understand how we're communicating and how folks are understanding the information that is given to them. So I'm a clinical social worker. I've been one for almost 30 years in the medical setting. And in social work, we do what's called a psychosocial assessment, which you might have heard of. And we're evaluating the social and cultural aspect of that family and that individual and what that social support system looks like. So if you're given information to take home that you need to consider what your options are, who's there to help you? What kind of communication do you have as a family? What are the norms in your family and who can you talk through things with to make sure you understand? We're looking at the language that you speak and the hearing levels that you have and the visual barriers that we might have. We might need to use Braille, for example. And then the comprehension and reading, it's not just through reading. It's also how your brain works with memory, how we're understanding and listening to what we're hearing. And that's why we do a lot of teach backs as well. On the next slide, we'll talk a little bit about some examples that I've had in my career in medical settings. So I learn really well with case examples. So I hope this is helpful to you all. So the first example is a gentleman who came to our clinic and had a blood draw, and my office was right next to the lab. And the phlebotomist, the person that drew the blood, printed, this is back in the day when they printed out your labs and handed them to you on a piece of paper. And they handed him the piece of paper and they said, your tests are negative, you're good to go. And all of a sudden he started sobbing. And they called me and we went to an exam room and we were talking. He had had an HIV/AIDS test, and on the paper it said negative, and it didn't explain that negative meant that he did not have evidence of disease and he was free of what he was being tested from. So he did not have AIDS or HIV. He had clean blood. He did not have any healthcare issues, but that piece of paper didn't explain that in language that he understood. So we had a conversation, talked through it with his family, and then I went back to the team and we talked a little bit about how are we presenting that information to our patients and how can we make sure that they understand what that looks like versus somebody handing you a piece of paper saying you're good to go. So in our system, we changed the way we educated people about their blood labs when they got them back. The second one was a referral I received. I was paged again a little bit ago when we used to have pagers for a gentleman that they told me couldn't read. So when I gave him information, they wanted to make sure I was aware he was illiterate. And once again, we had the conversation. I went in and talked with him and I asked him how he preferred to take information home to his family. And he said, well, I really like it in writing and I really like it so I can kind of sit and think about it and read it and talk to my family. And I said, well, I went through your chart and it looks like there might be some challenges with reading. Can you tell me a little bit about that? And he's like, well, I lost my glasses and I don't have the ability to pay for them. So it wasn't that he couldn't read because of literacy. It was he couldn't read because he didn't have the tools that he needed. So we made him a referral to get some glasses. So going back again to the team of figuring out how to ask those questions in a respectful way that consider his culture and consider his background, but also are respectful to make sure that we're understanding what he's communicating to us so he gets the right care and the right follow-up information. The third one is a family who was not English speaking as a first language. This was on the oncology side. And it was an older woman who came to us who received a diagnosis, but she did not understand it because she didn't speak English. And her family said, we'll take it from here and we'll translate. Well, going back to that slide we had about the federal guidelines, we are required in the United States in the healthcare system to inform the individual of what their diagnosis is and what their options are. If English is not their first language and they cannot understand English, we have to have a medically certified translator give them that information, and then they can make a choice with their family based on their culture and their system of if they would prefer to have a family member translate or if they would prefer to have the medical translator there with their family. So that conversation was a lot longer than I think our registration team realized when they paged us, but it was really important to talk about the nuances of culture in that family system and what that diagnosis meant, especially in that family. And the final one that I'll talk about is one from the emergency room. It was an older adult couple that came in. The woman, I think she was like 75, 76, presented with delirium, confusion. Her balance was off. She was having a hard time with word finding. She was sleepy. Her husband was very concerned. She had fallen. She had had some vomiting episodes at home. And one of the team members in the emergency room came in and started asking questions. How many stairs into your house? Are there any railings? Is your house safe? And this older gentleman built that house 50 years ago. And so he immediately got enraged because he thought they were saying that he couldn't take care of his wife. Well, if we step back, if that was your family, you'd want to know, why are they asking the questions? What is that information going to be used for? And how does it pertain to the healthcare situation you're sitting in? So having a conversation with that care team was, let's step back a minute and really realize that these people are in distress. We're in a situation they're not used to, and we need to be very clear about why we're asking and why we're being very intentional with that information and how we're going to use that for the best of their ability for an outcome. So those are just 4 of many examples. There's a healthcare panel, I believe, tomorrow afternoon as well, that I'm sure will be sharing some other experiences as well. Kate, if you could go to the next slide. And that's all to summarize to say that in the clinic, there's communication and health literacy is a very broad and complex situation. And it's considered, but it's always evolving and it's always getting better. There's quality assurance steps, there's federal regulations, but also there's a team initiative for the healthcare providers as well as the patients and families. So we want to make sure that everyone knows they have a role in health literacy. And that's from the clinical standpoint, but we're going to transition to the nonprofit organizations where Kate's going to highlight some of our work. Kate?
Thanks so much, Sam. That was super helpful. Loved the examples. And one of the things I was hearing was like, maybe things aren't always happening the way you want or the way that getting the outcome you want. So how can you be humble, reflect, do it differently the next time, tweak systems? So loving those. That was really, really great. So as Sam said, we are going to move on to looking at this through another lens on the education side. We get a ton of requests, from local chapters and partners to even just to individuals who want to go out and do outreach, whatever it may be. Like, it would be great if we had X, Y, or Z education initiative or a campaign on this, right? And so we want to actually think about this through the health literacy lens, because that's always one of the parts of our process when we are developing new educational materials and initiatives. So we're going to pull back the screen here a little bit, pull back the curtain, as they say, and walk you all through. So we'll start off with a slightly intimidating slide because these are all of the steps that we take. It's a lot, but I'm not going to go through every single step right now on this slide. I'm actually also going to use a little bit of a case study to walk through an example. And while it seems like a lot, we want to really break it down. So, if you're in an organizational setting, if you are a volunteer that's helping out, if you're in a clinical setting, whatever it may be, and you want to take some steps to maybe make some educational materials different, better, new, whatever it may be, that you can think about what of these might actually be relevant in your community. How could you take this, tweak this, go beyond? It's really here as a tool for all of you. So I'm going to share a little bit about our Thrive campaign. So this is a campaign that we did as part of a cooperative agreement with the Centers for Disease Control and Prevention. This cooperative agreement ended last fall, but our campaign information is still out there and going strong. And it really actually stemmed, the goal here is to raise awareness among individuals with bleeding disorders about essential, simple steps they can take to lead a healthy life. Sounds pretty easy, right? There's lots of steps to it. That is where we landed. This actually all came out of an inhibitor-focused arena from the CDC's initiatives. That was one of their priority areas to ensure people still know about inhibitors and know about the importance of annual screening for inhibitors if you are using factor replacement therapy. And so that was kind of a big task. People are a little bit afraid of the concept of inhibitors. They've heard some scary stories. So we had to be like, how do we build this messaging into something that is positive and empowering? And from that came Thrive. So the campaign was nationwide. nationwide and ended up being in English and Spanish. And we honed it to 6 key steps to living healthy with a bleeding disorder. But who can say it better than these adorable pictures? These are some of the young people who are in some of our workshops filling out our Thrive coloring books. We also have a picture here of Nicole Scappi, who is our lead program manager on this entire campaign. So huge shout out to her. But you can see here a few of the elements. We did social media, we had print publications, we had stuff online, the full gamut. And there's QR codes here if anybody is interested in actually seeing the campaign in English or Spanish. All right, so we were able to have pretty decent reach over the course of about 3 years. We launched the English first in 2024, 2.5 years, and then we were able to debut the Spanish after some thought, which we'll get into how we got to that. And so we were able to reach over 200,000 people, on our social media. We had 176 participants at workshops at our conference and at chapters all over the country. You can see all the numbers here, but really the point more, and here's a few more examples, is like, what was the impact? Through the end of that, more than half said that they would think about talking to their healthcare provider at their next clinic visit about Thrive, about the H in Thrive, which I'll get to what these letters are. You can see each letter, THRIVE, stands for one of those 6 steps that you can take. And H is have a conversation with your healthcare provider about annual inhibitor testing. And so the fact that 50% of people who had some contact with us were actually going to go do that in their following clinic visit to us was a really wonderful thing. So that's the what. Now let's back up and be like, well, how did we get there? Okay, so step 1, when we are building a new educational program or campaign, when we're thinking about how to incorporate health literacy, not as an afterthought, but throughout it as part of our checklist, is to not just have a few of us at NBDF, at the national office. It's not really an office, we're virtual, but connecting with each other on Zoom and just being like, hey, let's do our best, right? It is putting the lived experience experts, putting the patients' families, those impacted at the center of this. And we start that by always having a working group. Now, it's not just our LEEs, as we say, but we also have our healthcare providers, chapters, and other relevant stakeholders. In this case, it was CDC, who are usually part of that working group to ensure that the project goals make sense and set on a pathway for input and review. So sometimes even at the very beginning, we get feedback that's like, oh, that is not the way we should be heading to make this inclusive, to make this accessible. And we actually pivot kind of almost before we start. In this case, everybody seemed very excited to move down this pathway. So in the original phase, we recruited a working group in Spanish. That's that initial Thrive, in English, the initial Thrive working group. And then when we were ready to start thinking about the Spanish, we recruited a separate group incorporating a lot of the original folks to really ensure we had enough insights to be guiding the nuances and what might be different doing the full campaign in Spanish. And we also had a federal partner that we also needed to make sure that it went through all of their review, and they have lots of language requirements. So we really had a lot of dynamics. It took longer, but all of that made it so much stronger. And as you can see in this picture here are not only 2 of our working group members, Laura and Fela Chandi, that were at our Spanish. They were helped create the campaign, but also were at our Spanish Thrive workshop at our Bleeding Disorders Conference that was co-facilitated by Sonia Roger, who is also here in this picture with Nicole. So this was it in action, right? In those working group, I didn't get a virtual shot of us on any of those virtual calls of the full working group. I wish I would have, but at least you can see some of the folks in action. The actual lived experience voices completely shaped this campaign in a way that made it so much better. All right, so where possible, we also do step 2. And that's a needs assessment for whatever our target audience is. Now, this is one where I said where possible, because we get sometimes there's, depending on what kind of organization you're with, or if you're just an individual trying to do something, you might not have all the resources and capacity to do that. But where we cannot just get the insights of those in the working group, but really reach out to who you're trying to reach, that target audience, that will always help shape the education and communications that you have even more so. So this campaign originally started with English-speaking parents of children with hemophilia. This was sort of some of the honing that we did with the CDC on, sort of the main target audience. And so that's where we landed. And we did these initial needs assessments. It was both discussion groups and a survey. to help really guide this. But then the next step, step 3, is that we take those findings, right, this data, and actually bring it back to the working group to get the nuance. All right, so you're hearing this data from the community. What does this make you think? What direction should we now go in this, right? So it is really an iterative process. And so you can see we did in 2021 and 2022, we did some of these listening sessions as well as a survey itself. And this is, did we get some really good insights from these? So number 1, there are a lot of barriers, particularly for those that are mild or moderate, have mild or moderate hemophilia. They felt like, oh, am I at risk? Is my kid at risk for inhibitors too? So they sort of weren't as educated on inhibitor risk specifically, or as well as if they were an on-demand treatment instead of on continuous prophylaxis, ongoing regular treatment. And so they were sort of like looking at different subgroups really helped us understand who might already be getting this information on a regular basis and where might there be some gaps. How do we create a campaign that speaks to all of those? Because it was a national campaign, right? So it was really helpful for us to dive in and understand some of the nuance. And then particularly out of the listening groups, we got some amazing feedback. We heard people be like, inhibitors, I've heard scary stories. I shut down when I see that, or frankly, I almost didn't even sign up for this discussion group because my kid doesn't have an inhibitor. So I didn't even think this was for me. There was sort of a real divide is what we heard. We did hear some other people be like, I want to know everything about my kid's hemophilia. Let me figure this out. So I want to know all the details on inhibitors, even if it's scary. But we really heard a lot of people sharing, it's a little too much. If I'm just going to see messages about inhibitors, I'm going to think that's not for me and not pay attention to them. So we could go through all of this work and create something that frankly the community would not even watch or click on. Like that was going to defeat the point. So these listening groups, this needs assessment helped inform the whole direction of our campaign in a major way. What did we do next? Now we had to get into the messaging itself. Step 4, draft the materials and messaging. Sometimes in this particular round, we really worked very closely with our working group to help with some of the language. We also, as our team, did it, but it depends on your capacity and what you have. But if nothing else, even if we draft something, we always have our working group review and give feedback. It's a really critical point. Step 5 is reviewing of materials for reading level and audience inclusivity. And I'll go through in a minute here some resources and tools, like how do I do that, Kate? I have no idea. What level of reading should they even be at? Like, how do we get there? And then as you can see, once we've done some rounds of edits at every single stage, you are still doing that working group review of materials and messaging. So you can see working group review, getting your lived experiences, your experts, your chapters, your healthcare providers, that whole group together to review consistently. So some tips on how we achieved these 6 steps. We always aimed for, the standard is always 5th grade reading level. I would say we get somewhere between a 5th and 8th grade reading level, sometimes even just having the word hemophilia. It is not only a complicated medical term, it has multiple syllables. Those things matter. If you have, I love a good run-on sentence. It's just how I like get my thoughts out when I type. And so that's really not good for health literacy. So I have to go back, and it might be 3 separate thoughts that I've included in one sentence, and I need to cut that down, right? Break it into different parts. Those are all things that help with readability. And so on here, you can see there's a link. We'll make sure that people have access to this recording, so in case you're wanting this again. But that is one resource. There's many free resources out there where you can put in, you can just like cut chunks of your content. If you're drafting something, throw it in this reviewer, and it will tell you. This one actually checks multiple different readability standards to give you sort of an average score, but you can go into depth if you're into that, and to really help you understand. So I will say without fail, we always end up at the 12th grade level, and we're like, all right, we got work to do. We need to bring it down, right? So that's a big part of our time as our team is really working to hone and edit. Spelling out acronyms, sometimes things that feel to us like, oh, this is so many words, right? It's taking up too much space on the page, right? But you need to also be able, you want less is more, but you also need to describe the things. If you need to have a high medical term, or maybe you want to educate your audience on what that term means, then you need to make sure if you're using it, that then you're also really describing it in simple terms. If it's in parentheses next to it, in the next sentence, whatever it may be. Those are all things that help with the inclusive reading level language. we also like to think about not just the nitty-gritty and how we all write, but also thinking of it from a strengths-based approach, right? Can you have a positive frame that is empowering of your audience, right? Tapping into strengths they already have so they know they have the confidence to go do whatever that thing is that you may be asking them to learn or take action on, or a behavior change. And we also look to avoid shoulds. If we're telling people a lot like you should do this and should do that, then it kind of gets back to that old model of the experts always telling people what to do when they are really, quite frankly, experts in their own lived experience and how they navigate their healthcare. So how do we do that more in partnership through a strengths-based approach? And then really also looking at review for inclusion of various audiences. I have mentioned hemophilia on this specific example with Thrive because that was very specific to the campaign that we were doing and the funding partner. However, we know our audience. Our audience at NBDF isn't always just hemophilia. It's von Willebrand disease, ultra-rare factor deficiencies, platelet disorders. So what can we do? Can we ensure that women and girls are also included in this? How can we make our language generic, yet if it needs to be about hemophilia, be specific there too. So we always look at that. Is this inclusive across ages and stages? Like, who are we leaving out unintentionally by just doing this quickly, like slowing down and reviewing for different audiences? And then visual callouts of key points using infographics. All of those things help your education and materials become more readable. All right, so let's get to what did it actually look like, right? So step 7, we got the Word document with rounds and rounds of review and checking for inclusivity. And then we need to actually get into the layout. So we were very fortunate. We were able to work with some graphic designers that we had hired, and we gave them some key, you really have to very directly task, if you are not the creative type like me, task them with really clear instructions. If you have people on there, we want an inclusive audience, or, hey, we need to make sure that this is extremely visual. We need an icon, you can see over here on the right-hand side with Thrive, an icon that actually represents the words that are next to it. So for those that might be more visual learners, they can get the gist of it. So you can see this last one on the bottom, the THRIVE, the E is embrace. I mean, it's a little picture of a heart being hugged, right? So you can kind of see that as an example of how it's brought to life. On the middle document, it is questions to ask your healthcare provider about inhibitors. That's going to be a little text heavy, right? It's not as exciting, but we could visually break it up so people can quickly jump to the section that they need and find what they need. And then again, step 8, you all probably guessed it by now, working group review. There are things that we as staff who are driving this might think are super obvious because we've looked at this 5,000 times, and we need those fresh sets of eyes, and we need the community lens, and we need to make sure everybody on that working group feels empowered to share constructive feedback, right? So that they can be like, this one makes no sense, I have no idea, or I don't understand what that visual is, or I don't like these colors, or this one's actually visually hard to read because of some color blindness. It could be anything, and we are open to that feedback. All right, so we got Thrive in English. You all saw it on that last slide. We launched that campaign. Usually we really try and do things aligned so we can get Spanish in line to launch at the same time. But again, due to some restrictions, we had to launch English. And then sort of as that was getting close to launching, we were starting to build the Spanish. And here's why. We didn't want to just translate it. We felt really strongly that, this concept of thrive being a word that's meaningful in English, right? That, hey, that means I'm thriving with a bleeding disorder. It's catchy, but will that translate in Spanish? You can't just translate the words and maybe it just won't work. So we knew we had to do some digging in before we could really, start to flesh out that Spanish campaign. So steps 9 and 10 for us were translation and getting that insight to make sure it's not just the words were translated into preferred language, but what Samantha talked about earlier about, is it culturally inclusive language? Does it make sense, right? Is this going to resonate for your new target audience? And then we had that, that new Spanish working group that we had recruited to also do review of the translation as well as the design, the layout and design, right? So I will say this is a challenge. We have a lot in Spanish, but I have on here, if you don't have folks in a working group or don't have access to the community you're trying to target, maybe you're going for a newer community that you haven't done as much outreach. Another thing is to get some funding to be able to contract out and have translation done that way and have different folks, different voices at the table. So with that, I'm going to show you a video. I'm going to let one of our working group members share with you about their experience helping in this campaign.
Hello, my name is Fel Chandi, and my connection with the bleeding disorders is I have a son with who's 26 years old with hemophilia B, severe. Part of my role in the Thrive campaign was, well, of course, always volunteer to help the community. And this campaign was such a great experience because we were working in how to deal with the Thrive campaign and how to process that to the Spanish community. And one of the things was like, should we keep the same name? Should we just like do something else? But most of the community, members of the Spanish community says, no, it's going to be so much difference between, one another. We want to kind of keep the same name, and we're just going to try to accommodate the meaning of the Thrive campaign to the Spanish community. Actually, it is not. I think the closest is prosperar, which is prosperity. And so one of the things that we were dealing is like, how do we go from, Thrive to prosperar? And it's too big. So, and also the meaning of each word that's different. For example, T is toma, is like take, en cuenta, and then estrecha, from the last one is estrecha, is like stretch your arms, just kind of like, reach out, So we have to kind of come up with a lot of thinking of like, we want to make sure that it means the same, and that was really the big challenge. So it was really joyful on my end to work with different people from different areas, and we all kind of come together and arrange all this stuff to have a successful meaning to the Spanish community, but also to maintain the Thrive campaign. And it was fun. It was a lot of things. So I really encourage people to get involved, and with anytime it is something to help out in the community, get involved.
All right. Oops, let me pause on that before I dive in. So thank you to, there we go. Thank you to Fel and our entire working group who couldn't be represented here today, but for helping us. I was one of the people, I'm not going to lie, that was like, no, we're not going to have a campaign in Spanish that's all about that thriving, when that is literally like thrive, that's not a word in Spanish. And I was wrong. This is about the being humble part, the pieces that Samantha said about changing and going back and reflecting. And I could hear that. I was like, don't you want it to be more meaningful? But we got very clear feedback from the working group, the importance of having it be one campaign, that this Thrive campaign could be relevant to the Spanish speaking community as well. And even better, because you can tailor it and still make it work. And so they did that. They sat in like a Zoom session and hashed out, wait, maybe the T could be this, or maybe it could be that, So huge kudos to that group for helping guide us on a pathway to really making something be more successful, which we just adored. So I wanted to take one more quick minute. This is a shorter video just to show you the outcome of the campaign, because what is on here at the top, you can see what I was sharing all those steps, that was to get our educational content. I showed you the pictures of like the flyers and the questions to ask your healthcare provider. We had a workshop, we had various things. So that was just creating the materials. Then we actually had to get the word out there about it. We had to develop social media. We had to develop some videos that would help spread the word. And so for each of those steps, we did the same thing. We ran it by our working groups. We made sure it was translated, all of the things all over again. So I'm not going to go through all that, but I do want to show you the outcome of one of our short videos that we shared to spread the word about the Spanish campaign. So that was our campaign. It is still out there. We still have the resources and materials. One of the things before we get into final thoughts that I did also want to share, we had a few publications that we had created as part of the same cooperative agreement with the CDC. It was actually in a previous phase. We were still working on it, very inhibitor focused. It wasn't part of our Thrive messaging, but we had these as resources on our webpage for Thrive as well. And one of them is our Facts About Inhibitors booklet. You can see it here in this top left corner. You know, we've gotten questions over the years about various publications from NBDF, like why only Spanish? You know, you have everything in English and Spanish, and that's so amazing, but we have other language needs. And in 2017, we actually did an informal survey of HTCs and found out that Arabic and simplified Chinese were the next most requested languages at the HTC level. Now, it was a little dated. We've done, I believe our health equity team has done, you know, some additional work in this area, and there are additional language even beyond that. I think there's like over 350 or so languages spoken in the United States. So we are nonprofits, we have limited resources and time, yet we can do better, right? We can work to actually start to get this into more languages. I'm not going to lie, we also had felt a little intimidated by this over the years. We are very, you know, it's a wonderful benefit that we have some Spanish speaking staff here at NBDF. We felt like it was like easier to make sure we were on the right track. Part of that review is having folks, you know, that speak the language review it internally as well. So we had to get outside our comfort zone and be like, you know what, this is the campaign we're doing it on. And so for this particular book, this booklet covers like the basics. And we felt like this was the one to do. We translated it. You can see that our translations here into Arabic and simplified Chinese, those are both available now. But I bring this up not just to be like, yeah, we finally have this. We went through that whole process. We didn't have a working group, but we did have to hire 2 different consultants. We don't have staff at NBDF that could, you know, check and review translations. So we had one person or one company translate, and then we wanted to make sure we had other folks actually review that translation, since nobody in-house had that capacity. And I actually want to give a shout out to Fiona Robinson when she was at WFH, the World Federation of Hemophilia. She shared some of those kinds of approaches to doing things in multiple languages as they do around the world, and really meeting audiences where they're at. So we had to think differently. We had to budget differently, but this is what it takes sometimes to reach the audiences that we need. From this end, we actually, you know, by starting this, then people came and was like, oh my gosh, this is so amazing. If you do more things, I'm happy to volunteer and review. So maybe we don't need the same budget next time, but we have community members who want to be part of this now. We didn't know who they were, but we are slowly building that. And then the final thing I will say on this one is this image that you see on the left of the gentleman talking to his doctor. that when we first translated these, and this was like, we were behind deadline with CDC, and we also were running Thrive and getting that out. This is the reality that I will say, sometimes the rushing is not worth it, right? We posted the language translation with all of the visuals on the left, and it got posted on our website. And we just had a moment of, oh my gosh, we finally took a step back and we're like, how did we do this? We are the ones who did this. We posted this. It is not visually inclusive of the target audience. And so we quickly pulled them down. Thank goodness we caught it. We hadn't gotten complaints, but even if we would have, that would have been relevant to us to make sure that we're hearing from the community. And so as you can see, we have different visuals in the one in the middle than even the one on the right, because it is important to send, people learn through words and images as well as pictures. So all of that is super important to make sure is relevant to your target audience. And we had to learn that one the hard way. All right, that's it. I've talked a lot. We are excited to hear from you. If you have any questions coming soon, my final thoughts are, you're going to have to tailor something like this to your own organization's capacity, any timing restrictions, funder restrictions, as well as local needs. What worked for us nationally isn't necessarily going to work locally, right? You have a different target audience potentially. I think the biggest thing is that we know we don't get it right all the time or right away, but we are willing to keep trying. We're very proud of how Thrive turned out. It was through some stumbles along the way, and having a community that is so amazing to guide us on that and be partnering with us, that it didn't feel like huge stumbles. It was something we could really collaborate on. And then just like I said, create that environment of curiosity and being humble through the process, as well as, process and feedback improvement systems, build that into your plan. And maybe we don't always get it right away, but eventually we'll get there on target. And that's the whole point. It's not about us. It's about the community we're serving and ensuring those outcomes, improving those health outcomes, right? So I am done. Sam, I'm going to hand it back over to you.
Thank you, Kate. So many years in the clinic and having used those resources many, many times, it's so lovely to see the backside of how much thought and effort you and your team have put into it, and that it's evolving, right? We're all learning and growing together, which is so important. Thank you very much. So the resources and tools to advocate on the next slide, these are the resources that we pulled a lot of the information from. Spend a week talking about health literacy and the evolution of it, and how we're all continuing to do that quality check and make sure that we're serving the community. Some resources that can be helpful to you. We'll make sure that Dr. Norris and Karina have those in the lobby for the resources as well. I think this is our only resource slide. Yes, maybe one more.
Yeah, we have our presentation sources as well.
Oh yes, absolutely, yes.
So
with that, I think we have time for question and answer, if that's something that Dr. Norris and Karina would like to do.
Yes, thank you. Thank you, Kate. Thank you, Samantha. Wonderful job. We're so enthused by your presentation. The first question that we have is there a resource that includes words, phrases, and terms that community members would benefit from knowing?
Like a cheat sheet or glossary of simple, plain language, that kind of thing? Yeah, I mean, some of the resources that were the links that that Sam had up on the previous slide actually have a lot of examples. I have not found a glossary per se of like, here's all the words. Sam, you might have for a clinical setting, but a lot of those resources, they give a lot of examples of how to take, something kind of high in medical and translate it down to a much more understandable level.
Thanks, Kate. There are a couple resources on that you actually can learn how to write plain language summaries or transition those terms. Internally, I will say from the research department, when we have worked with lived experience experts, volunteers in the community, we have made cheat sheets of the acronyms and the terminology that we use. And we try to give that out while we're working with folks, but then also we held ourselves accountable in the fact that we really want lived experience experts to say, I don't know what you're talking about, please explain that to me. I can tell you as a social worker in many medical settings, in medical meetings in the clinic, I have had to raise my hand and say to a physician, I don't know what you're talking about. How am I going to help a patient understand that? And so having the ability to speak up and be inquisitive, you're not just showing that you are curious about it, you're also empowering the person that's speaking to think about how they're communicating. And that's really a gift to the person that you're asking the question to.
Love that. I will also add, we are actually working on, it's still in progress, we're calling it our Spanish glossary. It is lexicon. It is not, it is a little bit more meant to be an internal document, though we partner a lot with chapters. So we're happy to have this be a useful resource where relevant once it's finalized. But it was sort of like, we know there's lots of different ways to translate into Spanish. People use different words and sometimes they weren't resonating. And even in, if you go back to NHF, NBDF, various years, you might see the same kind of concept be talked about in Spanish in different ways. And so we're like, we can do better. We can hone to like, what is the community using the most? What are the known terms? And so we are starting to put that together, that when we share with a translator, like, here's a publication, please translate this, we're also sending along a document like that. So it's also something you can create as your own entity or organization. What are your shared terms that you think will make sure things will be at the best reading level or the most accessible for communication? And then share those with whoever's translating.
Excellent answers. Thank you so much. The next question asks, how might we ensure that we understand Lee preferred language?
Sam, do you want to take this first in the clinical setting? I'm happy to chime in on.
Oh, sure. So, I think it goes back to the relationship building. And if the question is coming from a clinician, obviously there's a lot to patient centered care and shared decision making, and really having the conversation in that teach back of whether or not it's a hands-on, making sure that there's a teach back actionable item or handouts or resources, making sure that we're talking the same language. But as far as, I'm sorry, go ahead, Kate. I have two different thoughts. I want to back up on what you're going to say. Go ahead.
Okay.
Too much coffee, too many racing thoughts.
Right. Yeah, we, I think on the, like I was mentioning before, we have to use some data. Yes. If it's a needs assessment, if it's data that's out there, like I mentioned before, we, had done a survey of HGCs back, at this point, it's almost 10 years ago in 2017 to see, what other languages are you all like hearing in clinic that we aren't translating our educational materials to? And then having other feedback streams. That's one. Is it social media? Is it other places? But if we're constantly asking these questions in English, you might be missing the audience on what's the next thing. So that is why going to other sources, like doing your own, survey of the HTCs or where people are already gathering and tracing those informal networks. So if you have folks that are coming to an event and they say, oh, I wish I would have brought my mom and my aunt and my grandma, but they can't because of X, then follow up, have that conversation with them, see what else, how many folks are not coming because, there's a language barrier, and start to sort of shape it. So a lot of it is, even though it's a broader reach kind of approach, a lot of it actually is still through the relationship building as well.
Absolutely. That follow-up and that evaluation of what was the service, how can we do better next time? That's a constant cycle, right? It's progress, not perfection. For sure.
Also, and this is a little like maybe silly, but it warmed my heart. I wanted to actually pull a clip in, but we didn't have enough time. For those of you who watched The Pit, I recommend it. I believe it was in season 1. There are a lot of both the culturally inclusive language as well as just preferred language, hiccups that they face and how they navigate it. And at one point, they just couldn't figure out what this person's preferred language was. And they pulled up a map of the world on their cell phone. One of the doctors did, and just let her point, and then they got the right translation services in. So sometimes you might have to think on your feet, is my point, right? And if you do that with that curiosity and humbleness, then it is coming from a place of care and collaboration.
Absolutely. Great answers. So the next question has to do with resources for existing barriers within health literacy when talking with providers and also when talking with payer systems or insurance companies.
So I think we're going to have a lot on like insurance and access and health literacy and other talks. So I would definitely show up for those. You'll get a lot more nuance in those sessions later in this summit. But I do think, some of the links that we shared on the references and resources slides are going to be useful in that. Like, this is not new news, right? Talking about, actually the term plain language comes like decades ago from Congress being like, all of our laws are too complicated. We need to make it in plain language. So not so much about health, and all of it got woven through. And so there actually are a lot of resources out there. I would start with some of those links as really good, like federal resources. If you are looking, I think I'd want to know a little bit more about like what kind of barriers you're facing and what, how we could help, really troubleshoot there, which I believe we did not put our emails on this slide, but I think both Samantha and I have said that we would be happy, to share our emails at some point and take any questions that way too, if somebody wants to get into the weeds more. But Sam, please, anything you want to add?
Yeah, I was just going back to one of our slides. I was trying to find the Health and Human Services website, and HRSA specifically has some amazing resources. And then also remember that, like, on the federal level, Joint Commission requires all sorts of regulatory plain language information and resources. So if you go back through the CDC and then the websites that we referenced, it will take you to the government sites, and there is a plethora of information there, and I would start there.
Perfect. And our last question, why can't we talk to or engage everyone at the same level?
That's an awesome question. So from the clinical standpoint, there's so much that goes into communication. There's so much. So health literacy is how we comprehend and understand. But from a social work perspective, also the stress of being in a clinic, the stress of being in a hospital situation or an unexpected medical situation or a new diagnosis or a change in diagnosis. So you have the emotional and mental health aspect of stress, plus you have the comprehension cognitively, plus you have the level of understanding and that health literacy and communication we were talking about. So communication is extremely complex. And so we need to look at it with absolutely every single individual, not a blanket system, at least in our realm in the clinical care. Kate?
Yeah, I mean, I think it's just, a really good question. That's a biggie. So thank you for it, stumping us here again. No, I mean, truly, as one of the slides at the very beginning, I mentioned that literacy overall is not going in the direction we'd like it in this country, in the United States. So, health literacy is a component then of that has added complications because of the medical training required to understand all of that high level language. And so, I think it's okay. And similar with such a diverse country of so many languages spoken, it is very hard to find singular, communications that's going to work for everyone. That doesn't mean that we are able to do the Thrive process, for example, on every single thing all the time, but we know where we're trying to work towards, and we do it as much as we can. And then find moments where, hey, if we've missed somebody, maybe we do something special and tailored for this audience and meeting their needs, So it's I think that would make everybody's lives easier, but we know that's not the reality, and that's not going to improve health outcomes. So we continue to strive to do what we can.
Thank you both so much. We have someone in the audience who loves what you said. Progress, not perfection. Yes. So with that being said, I'll give you each 1 minute to wrap up and give your final thoughts, and we'll close out.
Well, go for it, Kate.
I mean, this is a passion, doing education and communications out to the community. And, I even get frustrated in the process. This took us, over a year to get out like 6 letters. Like it seems a little like frustrating, but it is worth the wait sometimes. You're going to have to tailor things to make it fit for your environment and what sort of restrictions you're facing. But when you can, even just to pause and map out a plan and then see what you can actually achieve or not, depending on the restrictions you're facing, is going to be so worthwhile. Maybe it means that you've only been able to do 1 or 2 more things. You were able to use that readability checker. It's a free online tool. Let me at least do that in my next campaign or my next communication. I'll start there. That is a win. That is great. And let's be in it together, right? Let us know when we've missed something, and we're happy to collaborate.
Agreed. I was going to say partnership is definitely the key, because if you're trying to do it by yourself, it's just never going to be the end all be all. We have to work together, and we have to work together, especially in this community, because we're small but mighty, and really making sure that we're helping from a genuine place of curiosity and being very humble, like Kate said earlier, making sure that we are really focused on progress. So thank you for the opportunity.